Sure. So, good morning, everyone. Thank you for being here today. We have a very special guest today, our very own Dr. Ronica Yalamanchili, who, if you don't know her, she is a Keck medical student graduate, and she also completed her otolaryngology head neck surgery residency last year, and is our current and very first pediatric otolaryngology fellow at CHLA. So I think I can speak for those of us who have been working with Ronica in saying that we are proud to have such a talented, positive, and inspiring, just overall impressive individual as our fellow. I have had the honor of being part of her training experience working with her in the OR. It has been rewarding, to say the least, to watch how quickly she has grown and matured as an ear surgeon. At the same time, I have learned a lot from Ronica while we would tackle some of the most challenging ear cases that I've personally encountered. So I'm excited that today we get to all learn from Ronica about the evolution of cochlear implant candidacy. So without further ado, uh, everyone please let's welcome Dr. Ronica Yalamanchili.
Awesome. Thank you so much, Dr. Kang. That was so nice of you. Yes, good morning, everyone. I'm going to be presenting on cochlear implant candidacy and hopefully sharing some of the things that I've learned in these last 6 months of pediatric fellowship. Next thing is I don't have any financial disclosures. And the other thing I wanted to point out was that today I'm going to be, even though I'm doing a pediatric fellowship, I'm going to be talking about adults and pediatric for cochlear implantation. So just going over some of the general epidemiology, there's about 35 million people in the United States with hearing loss, and of those, about 1.2 million people with severe to profound hearing loss that could be cochlear implant candidates. And to date, we have implanted around 100,000 patients. And this number was from 2016, so it's definitely grown since then. This is the picture that I could find of the first cochlear implant device. It was approved by the FDA in 1984. And so just going over the FDA's timeline of approvals, that first device was a single channel implant. So one area of input for the patient. So that quickly evolved to multiple channel implants. That started or got FDA approval in adults in 1987. And then these devices were approved for children in 1990. And then as the years go on, the age of implantation that the FDA approves gets younger and younger based on the current evidence. So in 1990, it was 2 years. In 1998, they came down to 18 months, and in 2000, they came down to 12 months. And so now, routinely at CHLA, we're implanting kids around 12 months and even younger. Going back to 1985, when you're looking at the candidacy that the FDA had approved, they said bilateral severe to profound sensorineural hearing loss, and then they were using sentence recognition score, and their definition of candidacy was 0%. So that's obviously very, very limiting. Another trend that I want you to notice as we go over the evolution of cochlear implant candidacy is that sentence recognition has lost favor in favor of word recognition scores, the CNC score. That's due to the fact that multiple studies have shown that with sentence recognition, there's enough context that patients with the same amount of hearing loss may do better on the sentence recognition score than the CNC score, the word recognition score. However, functionally, they're functioning at the worst scores. So that sentence recognition score has fallen out of favor over the years. And then the latest candidacy criteria by the FDA was presented in 2005. So going over the adult criteria, they're looking at sentence recognition of 50% or less, or 60% or less in the best aided condition. In terms of Medicare, they actually have stricter criteria, which is less than 40% in the best aided condition. There are trials going on that are testing cochlear implants in the Medicare population and using the FDA approved criteria, and they're trying to get Medicare to rehaul their criteria so that they can be in line with the FDA. Going over pediatric patients, so from 2 to 17 years, if you can actually compare the hearing loss thresholds that they have in adults, it's actually stricter in kids, which is counterintuitive because we all know during the critical language development period, we want kids to be able to hear. And they have a different type of word recognition score, and that criteria seems stricter as well, as it's less than 30%. So it's interesting that, it's very counterintuitive that children would have stricter criteria than adults when we know that hearing is so important in language acquisition. So our very dear John DeParco, recognized this early on, and also recognized the importance of having sound clinical evidence to drive, expanding the criteria of cochlear implant candidacy. So he initiated a study to look at children who are being implanted, and it's a longitudinal prospective study that he started in 2002 to look at all aspects of hearing and language acquisition. The results of the studies, it was a 5-year study, supported early implantation because they showed that during this critical period, children who were implanted with cochlear implants, even though baseline they started behind their normal hearing peers, by the 5-year period of the study, they caught up to their normal hearing peers. So it's very important that children are implanted early on. And because of data from Dr. DeParco and others, the FDA's approved, patients to be implanted even younger and younger. So the current FDA implantation criteria for pediatric patients, it goes down to 9 months. And so when they're in that 9-month to 24-month period, they have to just have a audiogram that shows profound hearing loss, and a 3-month to 6-month trial of binaural amplification. So in terms of expanding implantation criteria, one thing that we noticed was patients with residual lower frequency hearing also did benefit from implantation. And specifically these hybrid electrodes that were shorter and therefore they only stimulated the higher frequency areas of the cochlea. And so these devices, 2 of them were approved in 2014, and the FDA criteria for that is adults 18 years and older, and again, the word recognition score of less than 60%. But you can see how we, based on the technology, have expanded the range of hearing loss that we can treat with cochlear implantation. Further expanding on cochlear implantation, now we're going to patients with single-sided deafness. So the FDA approved in 2019 for patients 5 years and older that they can be implanted for single-sided deafness. However, the criteria is pretty strict. They have to have 4 frequency pure tone average at 90 dB or greater in those lower and middle frequencies. And they have to show limited benefit from amplification. So their CNC word score amplified has to be 5% or less. And they have to have failure with a cross aid or other relevant hearing device. And also they cannot have single-sided deafness for more than 10 years. And that's the FDA criteria. There are studies that show patients implanted after 10 years do have some benefit. Implanted single-sided deafness patients actually experience a reduction in tinnitus as well as speech perception and noise, because now they have binaural hearing, sound localization, and quality of life. After tackling single-sided deafness, now the natural thing is to look at patients who traditionally were considered not candidates for cochlear implantation. So patients with cochlear anomalies, who, you know, the implants aren't necessarily made to fit a cochlea that's misshapen. However, you know, surgeons have pioneered, you know, placing these electrodes in cochleas that do have dysplasia. A systematic review of those outcomes show that postoperative speech perception, you know, improved and ranged from 54 to 84%, which, you know, some hearing is better than no hearing. That's kind of the thought in cochlear implantation. So that's a very good outcome. You know, although this was lower than reported outcomes when compared to cochlear implantation in normal anatomy, it's still meaningful. And I guess in their studies, they noted increased surgical difficulty, and there are many surgeons that have described different techniques of how you can differently place these electrodes in different types of cochlear malformations. But it's certainly not prohibitive to performing the surgery at all. And so when we're talking about improving hearing in patients who do have residual hearing, there's an effort towards minimizing trauma during the electrode insertion and preserving intracochlear structures such as the spiral ligament and the hair cells. And so improvements in surgical technique are going to continue to help us expand cochlear implant candidacy. One note is Dr. Arashi established that implantation itself induces apoptosis and impedes the reestablishment of residual hearing. So he showed that in vivo studies. And so manufacturers are working to make the coils that are less traumatic, but he pointed out in his in vivo study just that inflammatory cytokines and oxidative stress is happening. So possibly the answer isn't just to make the electrodes thinner and thinner, there might need to be other interventions that we can do to preserve the cochlear structures and the hair cells. Electrode length is something that has been identified as a critical factor. Greater insertion depth provides speech perception in traditional candidates, but may destroy residual hearing. And shorter electrodes, which preserve that residual hearing, may compromise outcomes for patients who later on lose that lower frequency hearing, and they require electrical stimulation. In cochlear implantation, when they're talking about hearing preservation, they talk about techniques for soft surgery. So optimizing the insertion depth, which has been described as 360 degrees, thinner electrodes to cause less trauma, and also round window insertions. The idea is to get an atraumatic scala tympani insertion. And so cochleostomy versus round window insertion gets you the best chance of getting an atraumatic scala tympani insertion. So that's why round window insertion is considered one of the soft surgery techniques. One of the interesting papers I came across was intraoperative electrocochleography. They can actually detect cochlear hair cell and neural responses through the electrode array as you're placing it. And so you're getting intraoperative feedback as you're inserting the electrode that can influence your depth of insertion or speed of insertion, which may affect hearing preservation. This is a figure from a paper that Dr. Kang has cited, and we've been looking at it when we're doing our cochlear implant surgeries. But it's the idea of the intermediate cochleostomy. And so these surgeons from Italy did a cadaver study where they kind of defined the anatomy of the round window and the round window membrane as seen by the surgeon during cochlear implant insertion and cochleostomy. And so if you can see my arrow, they have the facial nerve mastoid plane defined here, and then they have a perpendicular, which is the X plane, and then they have a parallel line to that, which is considered the Y. And the Y is based right at the top of the round window membrane. And again, this is a right-sided ear. I didn't explain that. So this is a right ear, and so this is superior. And so the placement of these planes is kind of based right on the round window membrane being in this superior posterior quadrant. And so when they did the cadaver study, they wanted to see, you know, depending on where they made the cochleostomy, where is which cadaver specimen had the least traumatic insertion and full scala tympani insertion. And so they found that where this green circle is, so they call this an intermediate cochleostomy because it's not in this quadrant or this quadrant, it gave them the best results. And so, you know, it's studies like this that push forward the science of how we're placing these electrodes and how we can preserve hearing, and helps us expand the cochlear implant candidacy criteria. We also have improvements in electrode design. So we have the traditional like hybrid electrode from Cochlear, which is the shorter electrode. And then the most most common electrode that we've been placing at CHLA is this contour advanced electrode that's actually perimodiolar, and that's another technique of trying to have efficient electrical stimulation, but still have minimal trauma. And so one of the newer electrodes is the 422 slim straight electrode. And so this has few of the characteristics of a soft cochlear insertion in terms of it's thinner, and it has the ideal insertion depth for hearing preservation. So there's trials, they're using this electrode to actually even expand on the FDA-approved cochlear implant candidacy criteria. So this trial, where they used aided word scores between 10% and 50% in the ear to be implanted, and up to 70% contralaterally. So you can see on the audiogram, there was a huge range of hearing loss that they that were candidates for this trial. And then they did show that these patients had audiometric benefit after being implanted. So patients, so it shows that, you know, we can continue to expand cochlear implant candidacy criteria based on the new advances in technology of electrode implants. Now I'm moving on to cochlear implant underutilization. And this is the idea that of those 1.2 million people that have severe to profound hearing loss, some proportion of them don't benefit from hearing aids, but we're not getting to all of them, and we're not offering all of them cochlear implantation. And the question is, you know, what has that looked like over the years, and why are we not getting to all of the patients who could use this technology? So an analysis of the preoperative auditory profiles of cochlear implant recipients since 2001 showed that the mean preoperative CNC score of cochlear implant recipients in 2001 was 3%. So if the FDA approved criteria was less than 60% and the mean preoperative score is 3%, it seems like we're missing a lot of people. And then another study in 2018 showed that their patients, the mean preoperative CNC score was 10%. So there's a lot of opportunity that people have identified that's being missed in terms of expanding the criteria, but also capturing all the patients who already do meet the criteria. This paper from 2020 actually looked, it was very large cohort of patients. They looked at 1,600 cochlear implant recipients. They looked at the pre and post-operative AZBio sentence scores in quiet and in noise. And so the idea for comparing quiet to noise was that, you know, functionally, patients have difficulty with language acquisition and perception when they're in a normal environment. So a normal environment would be signal to noise ratio of, you know, 5 or 10 dB. And so that kind of makes sense, is that maybe we shouldn't test the sentence scores in quiet, we should test them in noise, because functionally most patients, when they're in the world, they're in noise. So they looked at patients who had who qualified for cochlear implantation on the quiet AZBio, and then they looked at patients who didn't qualify in the quiet sentence score, but they did qualify when we added noise. So they looked at plus 10 dB and plus 5 dB. And so that's the signal to noise ratio. So actually plus 5 dB is the harder test. And so when they looked at that, and they looked at patients who got the cochlear implant preoperatively, their sentence scores all improved compared to post-operatively. And then when you were looking at patients who had who qualified with noise, they all improved as well in terms of preoperative and postoperative. So what this shows is that we can expand the cochlear implant candidacy criteria by looking at testing sentence and word recognition scores in noise. And then when we're talking about underutilization, another issue is that maybe we're not getting referred the patients who qualify for cochlear implant. So one group looked at how we can make this easier for primary care providers, and they came up with something called the 60-60 guideline for referring adults to a cochlear implant candidacy evaluation. And so they said using the word score that's less than or equal to 60%, and a pure tone average that's that's greater than or equal to 60%. And so it's easier for primary care providers if they see the number 60 or less, or 60 or greater in the pure tone average, then they would just automatically think to refer. So this is something on ENTs as a specialty to work on in terms of, or people who are doing cochlear implantation, to work on disseminating this type of information to primary care providers, so that we can increase the amount of referrals that come to the cochlear implant centers. And so one of the papers showed that if you use the 60% guideline, of the patients who do end up coming for cochlear implant evaluation, 96% of them, were a cochlear implant candidate. And then another note, I wanted to look at the controversy of cochlear implants and the deaf community when we're talking about expanding cochlear implant candidacy criteria. And so initially there was controversy that cochlear implantation is an attack on culture of the deaf community. However, this author actually looked at just the general how they teach patients who grow up in the deaf community, and there's a huge number of educators that are now teaching patients. They're teaching more, with how they write it, bilingual approach. So they teach sign language, and they teach, the different speech language therapy that you need for patients with cochlear implantation. So I think it's important for us to recognize that this is a trend, and to be sensitive to it, and open to hearing from people in this community. And so that's the end of the presentation. Overall, I think it's really exciting that cochlear implant candidacy is evolving, and it really is coming from the pioneers in cochlear implantation surgery, who are, pushing the boundaries of surgical technique, and then the implant companies that are pushing the boundaries of processing and implant electrode design, and I think in terms of utilization, there are patients that need this technology that have not gotten it yet. And so, you know, combining all of that is a greater task. And but it all starts with understanding where cochlear implant candidacy started and where it's going. So that's what I was hoping to share with you all today with this talk. Thank you. And I can take questions.
Ronica, that was really a great talk. This is Courtney Volker.
Hi.
A really great summary of sort of the history of how things have evolved. Just a couple comments. The underutilization area that you covered is really, really important. We're, even with all of the things you talked about in place, as you mentioned, we're not getting to the high percentage of population that would really benefit from this technology. The criteria that has been laid out is important to address, but a lot of the primary care doctors, well, probably all of them, don't understand, you know, decibels and cutoffs and thresholds and all of that. Even some community audiologists get kind of lost in those weeds. And so when we're all going out to communities, I have found a really good, easy screening question for folks is just to ask the patient, is your patient having trouble with their current hearing aids in understanding over the telephone? And if the answer is yes, then that's just a good way for the doctor or anyone, even family members, anyone can then just send to us. And then we can kind of take it from there. It's better to err on the side of, oh, they're not a candidate yet, than the patient not getting in the door. So I've even, you know, we have to go out to the communities and educate not only the physicians, but sometimes even bypassing the medical community and going right to the patient and the families to get in the front door. So that was a great talk, and I really appreciate you covering this topic.
Thank you.
Hey, Ronica, this is Joe. Can you hear me?
Yes, hi.
Hey, that was an awesome talk. Thank you. My question was, I was wondering if, as the criteria for CIs continue to change, if there's any barriers to getting insurance to cover it, especially with like the different age groups and things constantly changing, and how our community and you know, gets the people who pay to agree to cover it.
Yeah, so obviously insurance follows the FDA criteria, and then CCS is the main insurance for children. That's like the Medi-Cal for children, basically. And so I'm looking it up right now. It says presence of moderate to sloping severe sensory neural hearing loss, full-time hearing aid use, consistent appointment, and family demonstration. With either candidacy should be extended to children. Yeah, so even the CCS criteria is pretty strict. They're saying they want, yeah, the family to demonstrate complex communication with either oral or sign language. And so there's a lot of barriers there in terms of qualifying insurance-wise for cochlear implants. I think in terms of what the cochlear implant centers do and what Caruso Center does is streamline the process and kind of take the patients through each step. And I think that definitely helps, but there are a lot of barriers that even I haven't encountered. I hear about them, but I don't exactly know where the sticking points are in terms of like steps of getting insurance to approve things. And so just on average of like patients when they start at the Caruso Center, to when their their CI evaluation is finished and insurance has approved them to get a cochlear implant. That whole process takes months. It takes like 4 months, I think. And so I think that's definitely a barrier to them getting it. In terms of, is your question more towards, is insurance following the expanded criteria that I was talking about?
Yeah, I mean, you've already answered a good part of the question. I just think it's like important to acknowledge that there are barriers, and we have to be cognizant of, you know, possible disparities that would come up for people who can't pay for this. But yeah, I mean, if the criteria are changing and they're expanded criteria, I wonder what the process is in then getting it approved by insurance.
Yeah, so studies that are prospective and longitudinal, things like Dr. Naparko was doing, those did help change criteria. So his study showed that you need to implant the kids earlier and earlier. And so FDA approvals change with that, and then insurance follows FDA. So that's kind of how it goes.
It's a constant battle. It's
Yeah.
a constant battle, Joe, because you would think that's how it would go, and that would seem rational about how it would go, but it's not how it goes every day, because the insurance can't keep up with the changing criteria all the time. So for instance, actually the new FDA is 9 months now, not 12 months. And so and then you know,
the newest data shows 6 months. What I was reading was it's
so
safe up to 6 months and effective.
Yeah, and so when you talk, and this is why it's so important as us as physicians to be advocates, not only for our patients, but to get on, you know, the government committees, and like Debbie and I are on the committee that communicates with CCS to educate them about, like, 9 months, there was no scientific data to show that. Ronica, you're absolutely right. The scientific data was that 6 months, the study was 6 months compared to 1 year had benefit. But the FDA just kind of randomly chose 9 months for a middle point. And so it's up to us as physicians to keep pushing and say, no, actually the data is showing younger. And then the insurance can't keep up with all that. And so it's a constant battle advocating for your patients. They get denied. You have to go back. You have to speak with them. So it's a great question, Joe. And it's very frustrating for the providers and the surgeons, and then also obviously for the families who want the best for their children. So that's a great question.
Thanks, Joe.
Thanks, guys.
So I just want to comment. Thank you so much, Veronica. That was a great talk. I just want to comment about the soft insertion theory that you had mentioned. And at Iowa, actually, one of the residents had developed a device that very slowly advances the electrode into the cochlea.
Yeah, I heard that at different academy talks too, that slow insertion, yeah.
Right. So I haven't seen it myself, but it takes a long time, and but it's a very controlled mechanical insertion. You can actually, I think they measured in vitro that the forces and the pressure generated on the basal membrane are much lower than when done manually. So another learning point from that is that even as residents, you can invent something, and so that resident actually ended up starting a company just based on that.
Yeah, and I think I remember from those talks that they were saying to insert it over like 13 minutes. Like that's why you need the mechanical insertion, because nobody's gonna sit there for 13 minutes. Well, thank you, everyone.
Thank you so much, Ronica.
Thanks, Ronica. Great talk.
Thank you.